So we have filled you full of information, and we have allowed you to have a little bit of breakout time and chat amongst yourselves. But now that you have all the information, with the exception of what Mary is going to talk about, I thought I would tell you a story. It relates to the PCORI project that you just got through hearing about. PCORI, the Patient-Centered Outcomes Research Institute, set out to change culture. They didn't say that out loud, but they really set out to change culture. And the way they sought to do it was through community-based participatory research. And they didn't say that out loud even. But what they did was award a whole lot of money, almost $10 million, to 14 sites in 8 states, all focused on improving the transition of care from pediatric to adult sickle cell care. This was landmark, one of the largest grants they've ever awarded. The 14 sites had never, in some cases, had research grants. The research grants, by definition, included money to go to community-based organizations. And the design of the study was that we were going to randomize sites to become a site where peer mentoring was utilized to help adolescents cross that bridge we talked about on day one between adult and pediatric care, versus sites where peer mentoring was not used, but with one huge twist: culture change, regardless of whether the site was randomized to have peer mentoring or not. What was that culture change? Let's go back and look at Shirley's slide a minute ago with the 2 triangles. Oh, I can do that. Yep, that's the one. Get it right in a second. That's the one. Take a look at that slide. Do you understand, if you have been working in sickle cell disease, do you understand that until maybe 20 years ago, there were no lines between those circles? In fact, the adult circle was a pretty small one, if it existed at all, in the top right. The pediatric circle was a pretty good size one, but it wasn't very well organized. And the CBO circle might or might not have existed. Not only did PCORI decide that each of those circles need to exist, they decided that we needed to speak as one, to act as one. There is the culture change. That the pediatric and the adult program, and I'm now looking at the larger triangle, the pediatric and the adult program needed to stop thinking of themselves as separate, and the pediatric and adult program needed to communicate with the CBO with the patient, and vice versa. Now, that is like bringing together 3 sets of cultures. In fact, I had a slide in one of my talks in which I talked about the 3 cultures: the culture of medicine, the culture of patients, and the majority of culture in the case of sickle cell disease, which does not necessarily relate to the culture of the patients. It was like bringing those 3 cultures together and have them have a giant United Nations. Can I just tell you that even the pediatric and adult collaboration has taken a long time to really cement? That in the top right-hand corner, that triad, just the relationship between the pediatric and the adult program. We're still working on those relationships. So melding those two programs into one program has taken time and work. Now, where we're at in most of America is we have fledgling CBOs, as has been shown to you. Even though sometimes they are old and have been around, they often have one funding source. They often are not staffed by full-time people, and they often feel left out of all the activities going on in the medical center. And then vice versa, the pediatric and the adult programs often don't know what is going on in the community. Really good stuff going on in the community. They've not done a windshield survey. They've not assessed the resources available in the community to help them, the medical care team, do their job. They don't have community health workers, and they don't have a communication vehicle to make this relationship strong. PCORI said, we're going to help you do that. And so we've now been on a 4-year journey to develop this term, triad. And so I want to tell you that it has hurt me to give up some of my previous autonomy to do what the heck I wanted to with my patients, and to actually give patients a voice and actually have to work with a community-based organization that knows a little bit about what I do, but not a whole lot about what I do, but has some ideas that they would like to tell me what to do. That is something that Joan talked about a minute ago. And that is something that Ben talked about in his talk. Our cultures have had to mingle. We have had to really work and really operate. And I am sort of saying, I'm going to say we're on the road to having a culture that allows for equal voice. The principles of community-based participatory research are that the community knows what it needs and can tell you what it needs and can help you implement what it needs. What you're bringing is some expertise, often some funding, and a big pair of ears and not just a mouth. So that's my soapbox that I'm on right now, is that all of sickle cell care to date has been sort of top-down, government telling the sickle cell programs what to do, the sickle cell programs telling the community and the patient what needs to be done, and we walk in thinking we know what to do. And you've heard from this conference that that's just bass backwards. We shouldn't be doing that. But I'm also telling you that the culture change to reverse that is significant. And PCORI has, it's patient-centered is the first two words in that whole title for this entire federal agency. Just in case you wonder, this is a federal agency, the Patient-Centered Outcomes Research Institute. It was created with Obamacare money, and all they are about is making care more patient-centered. So with that, let's open up our mics. I'm going to read a comment that is on the screen already from Ray in Minnesota. She says, the culture shift began the trajectory change that we are still committed to. I think she means in Minnesota. And Ray, you're going to have to unmic and just tell us the whole story, girl. Thanks to the early and recent innovators of this shift. And Ray, you may remember when she introduced herself, Ray has a unique position. She was sort of on the inside of the medical center, but also a member of the community and also the parent of a patient. So as much as anybody, she can speak with some authority. Unmute yourself and say something profound for us. Ray.
Well, thank you. Thank you very much. I'm honored. And this conference is amazing. I was at the very first one where we were all collectively in the same room, and the energy in that room was very indicative of where this program was going, and we are still seeing the fruits of that. But yes, I've been blessed enough to kind of, I wear kind of a trifecta hat as a parent of a now young adult living with sickle cell disease, also as a member of the clinical team for several years. And only recently I transitioned out of the clinic in order to focus on the community-based organization, the infrastructure and capacity building of that organization to prepare for this very shift that Dr. Smith is talking about. And I would say that even before I had any of those titles, I was just simply a parent who wanted to see their child live. I didn't choose this road because, that this was one of the options when I went to college. I chose this road because of the necessity and the absence of community resources and clinical voices and individuals that look like us, particularly in the state of Minnesota. So all of this information is so critically important. I don't think that you can do this work without all of those components. I think that when we work we work together, we have better outcomes. And it is about showing the community that we can partner. It is not that we should be working in silos. It's not, well, my community told me this, well, my doctor told me this, well, the transplant team told me this. We need to be working together so that the community can feel a sense of trust, as well as a sense of pride in the relationships that they are building. But that goes both ways, and it goes all around the table. And then not only are we changing individual hearts, but we're changing policies and practices as well.
So let's riff off of each other. Changing individual hearts is a matter of personal, cultural change. And changing policies happens when lots of people decide they each agree with one another that the policies don't line up with their personal values. It has been my experience, Ray, see if you agree with this. It's been my experience that you gotta have champions in each of those domains, those three domains there, talk to one another and decide that we're going to be one for all and all for one. One of our community-based organization members came up with a slogan in preparation for a site visit we're about to have from Picori. Now listen to this. It's one for all and all, F-O-U-R, one, relating to the quadrad. Do you see that? All for that. One and one, F-O-U-R, all. So no more triangles, one big quadrangle, all for one. I thought that was a cool...
That's exactly right. I want to give a shout out to the Sickle Cell Consortium, who really began coining this term of nothing for us without us.
Oh, that's another powerful one. And was that Lakia?
That was Dr. Bailey, yes, Lakia Bailey.
So let's describe Lakia. Lakia is another person who's sort of a triple threat the way Ray is. She is a warrior living with sickle cell disease. She is a researcher. And she has founded a community-based organization and now a consortium of community-based organizations, the Sickle Cell Consortium. Say a little bit more, Ray.
Yeah, it is. I think that the concept of what began as just individual advocates coming together, and it was about creating a space for voices. It was about elevating community voices who were not being heard. And that happened so many years ago. And then over time, it really turned into this collaborative effort. And then it was whose voices are not at the table, who are making decisions about our health. And so it has grown since then, and it includes the fact that it is patient-powered, right? And when we say patient-powered, we mean community-powered, meaning that it is individuals living with sickle cell disease of all ages. So not only do they really work well with adults living with sickle cell disease, but it's also children who are living with sickle cell disease. They were a critical piece of getting through the pandemic in the early months of the pandemic. pandemic because they created child meetings and Zooms and education that would keep your child engaged in their health during that time. They've created Warrior University so that there is ongoing education and not independent education, but partnering with sickle cell medical experts that in known facilities who are well known around the world to present this education and information. So we have really begun to look through a different lens at the ways that we can incorporate not just the patient voice, but the community voice, so that even as pharma begins to make available some of these other options for therapies, that we can have community discussions that allow people not only to know that they exist, but understand the why behind why they exist. We have the advantage of being able to take a lot more time with patients than we know is typically available in the healthcare setting.
Two things strike me from what you just said: responsibility and capacity. What do I mean? It's one thing to be a passive patient, doing what you're told. Take your medicines, come to the clinic appointment, do this, go there. It's quite another thing to be told, you're in charge of your destiny now. I'm your advisor. Where would you like to go? That can be daunting for some patients and families. Have you seen that? That's the first question. And then the second question is capacity. Often, community-based organizations view themselves through the lens of financial capacity rather than community assets. The Windshield survey was meant to help people understand that even if you don't have dollar bills, you still have assets, you still have resources. How many communities, in your guess, of patients with sickle cell disease take that approach rather than the approach of, I'm just part-time, I don't have no money, we don't have a treasury, we can't do much? Start with the first question, the responsibility one.
I think that responsibility, I think that as we have embraced more of a patient-centered model, that responsibility becomes a shared responsibility. I can tell you that when my son was very young, sometimes it astounded me that I actually had a job working with the sickle cell team, because in the early years, I was that mom. I wasn't the mom that came in, cursing people out, but I asked a lot of questions. I asked a lot of whys. And at that time, 25 years ago, it was not common to have to answer to your why. A physician gave an instruction and you followed it because they were the letter of the law during that time. I didn't know what I was embarking upon, but what I was trying to do was not only be involved in his care, but I was trying to take on a responsibility that said, I also need to prepare him to take on his care. And so I do think that, and I say it like that because it is a shared responsibility, but then we also look at what is the influence of the community, what is the influence of the caregiver in outcomes, and how do we really capitalize on the influence that community has? Mm-hmm. But how do we also make sure, as was discussed today, that the influence of the community comes from a science-based understanding of what is available, so that we are making informed decisions and we are educating through a lens of information and not just emotion.
Yep. And then what about the second issue with misjudging capacity, underestimating capacity?
Well, I can tell you that I have been, my son is 25, and I've been doing this work for about almost 18 years. And I can tell you that it certainly is not about money. I think that we have, as a community, and certainly community-based organizations and advocacy organizations, have probably done the most with the least amount of money that that one could possibly imagine. Many of us do this with no kind of payment or stipend. Some organizations have staff that help them to carry the load and to build capacity. Some are getting to that place and growing from a grassroots place. But funding is something that we've not had the luxury of getting. And then when there is funding, it is so spread thin across all of these organizations that are really trying to do the right thing. And so as we continue to create infrastructure, as we continue to partner with institutions that already exist, as we continue to show our value, we continue to be able to access more sources of income so that we can partner in more robust ways.
Mm-hmm. Yeah. Okay. We have said our piece. Let's have some other people say theirs. You may ask a question. You may unmic and register an opinion. You can talk about anything we've talked about over the last 3 days. I have a question on the screen that I'm looking at, but I won't answer it quite yet. But I want to give people a chance to review and reflect.
Anything we've talked about over the last 3 days, correct?
Yeah.
Hi, I'm Diane Creekmore. I'm from Virginia Beach, Virginia.
Hi, Diane.
I'm a mother of 2 adults and 1 adult granddaughter. You all were speaking in regards to stem cell transplant or gene therapy. Could you elaborate? I know you went in great detail about some of the treatments and therapies out there now, but could you elaborate in great detail about the gene therapy? How serious is it? Like when bone marrow years ago would be suggested, years ago, it was like a patient would have to be 50% living, 50% to death. But at what point in a sickle cell person's life now
That's good. That's a good question.
gene therapies recommended? Is it
Well, you actually asked 2 good questions, and I'll answer this the survival question. I'll answer that one first. Diane, we're at the point now where the average person offered a stem cell transplant has a 90% chance of surviving that transplant, not dying. And it could be better than that. Children might be a little bit better than adults. That's a long way from where we used to be. As you said, it used to be like maybe 50%. But now people survive the procedure at a rate of something like 90%. And I'm speaking of an adult trial recently concluded called the STRIDE 2 study. That is not the same thing as saying it's going to work. And so that is closer to maybe 70%, depending on the type of transplant you have. And it's not saying that you won't have any complications. There definitely are complications. That's the first question. And then the second question is a more difficult one. How do you know it's time? And we're still struggling with that, Diane. I'd be lying if I told you we had very clear-cut criteria. I'll put it this way. You need to be sick enough that it matters, but not so sick that you can't survive the procedure. How's that for being vague?
Okay, so that I understand. So the difference in the CRISPR gene therapy and the stem cell are...
Yeah. Okay, I can give a simple way of thinking about it.
Okay.
Are you going to take somebody else's cells into your body? Or are you going to give up some of your cells and we treat those cells and put them back into your body? That's a real simple way of thinking about it. So a stem cell transplant, you're taking somebody else's cells. Gene therapy, you are having your own cells altered, and then they're put back into your body.
Okay, I understand that. Thank you. Thank you, Dr. Smith.
somebody put in the chat the treatment of crisis, and it's a general question: how do you treat crises? And so we did go over that a little bit on day one, I believe. But I will say this carefully, quickly, completely. And I would love to tell you that we do that. Number one, we don't do it quickly. The standard of care now, the highest quality care, and this is published literature, the highest quality care for crisis treatment is not treatment in the emergency department. It's treatment in a dedicated sickle cell infusion center. You get quicker treatment. The satisfaction with analgesia is higher. The likelihood of being admitted to the hospital is lower. Not everybody has that luxury, however. Virginia Commonwealth University currently is struggling to have that luxury. We don't have it. We had a modicum of it for a while, but we're trying to resurrect that treatment model. Failing that, you are going to get them some kind of analgesia within 30 minutes of registration, within an hour of arrival at the medical center. You are going to treat until the pain is reasonably controlled. It does not have to be opioids, but opioids are usually a part of that therapy. And then you are going to discharge them with enough analgesia so that they go home and don't come back quickly. Those are the sort of three key points. Get to them quickly, go up and up on the therapy until you break the pain cycle, and then send them home with something that will, most of the time the crisis is not over when you send the patient home. A pioneer doctor wants to give us some wise words, and she lives in Detroit, and I happen to know some good news has happened to Detroit. You can give us the good news while you're making your other points. Dr. Wanda Witten-Sherney. Take it,
Thanks
Wanda.
so much. Thanks so much, Wally. I first want to say how fantastic this conference has been for me, how much I've learned. And unfortunately, this was my first time participating, but it definitely will not be my last time. So I'm so glad I've been involved. The point that I wanted to make is that I wanted to share the importance of our connection to the Michigan Department of Health and Human Services and the fact that we're the coordinating center for newborn hemoglobinopathy screening in the state. And so one of the key issues in the NASM report is trying to standardize the way we do sickle cell trait follow-up. And I think that's really a way, if you're connected to your health department, then that's really a way that you could get some funding and do some good work so that we make sure that people are aware of their trait status. Now, mind you, we're doing that during the newborn period. So we're telling a mother about the fact that she might have grandchildren with sickle cell disease when we explain the genetics, but at least we get to her at some point, and we'd like to get back to them later on. And we actually got some funding to bring back something that was similar to the mobile unit that my father had.
Okay. Who was your father? I'm not going to let you get away without saying that.
And you know, I wasn't going to get away without saying that. One of the things I say quite often is that we stand on the shoulders of our ancestors, and both of my feet are planted firmly on the shoulders of Dr. Charles F. Witten. That's my father. And he died 10 years ago from multiple myeloma, but we are celebrating our 50th anniversary, and I am sure that his spirit is smiling down on us because we have so far a total of $2 million and so many people that are involved in trying to start the Charles F. Witten Center of Excellence for Sickle Cell Disease in Detroit. So you will all be invited to the ribbon cutting. I'm really putting it out there into the universe. It's really going to happen. So thank you so much, Wally.
Yeah, that's a cool thing. And it's not just Detroit. States are starting to have a soul. And we're going to hear from California here after the break. Guys, we could talk about sickle cell disease for days, but we know you have fanny fatigue and probably a little bit need to walk around, take a break. So we're going to let you do that. Are we on for 15 minutes? How long? 15 minutes? 15 minutes, and then we're going to hear from the great state of California, and Mary Brown is going to take us home. Hope you're having a good time. Go get a break.